I don't have any cool pictures. I don't have any procedures to show you. And I know my hosts are not big believers in this, so I'll keep it light. We can talk about what is hypersensitivity. So there's no argument here. It's a type 4 reaction, delayed type driven by T cells and pro-inflammatory cytokines caused by an exposure to an antigen. Metal hypersensitivity in the context of metal implants, we can debate if it's due to corrosion, metal ion release, antigenic complex formation, or an immune response. So there's some older papers, some of them I was still a baby, looking at allergic eczema from metallic foreign bodies, metal sensitivity caused by loosened joint prosthesis. So these are some of the historic things. So the question is it a cause or an effect if we do think that it actually happens? Does the metal hypersensitivity lead to an implant failure, or is it the implant that fails leads us to develop a metal hypersensitivity? So if we look at metal hypersensitivity in the general population, unrelated, we know that nickel is probably the most highest frequently, much more frequent in women. And you can see a lot of women that have jewelry exposure. I'm not talking about our wives that tell us that we need to buy gold instead of other stuff. But it's we do see that in cheap jewelry, especially in the ears and even in kids. Cobalt, chrome, titanium. Titanium is probably the most inert out of the metals that we tend to use. And these usually overlap with some alloys that we use in arthroplasty, and that's where everything comes. The cobalt chromium alloy that we use a lot contains nickel, and that's the problem there, that at least we think it does. So what are the symptoms and the patients, the rare ones that may have a hypersensitivity? And these are a few pictures of patients that had that. They'll come with pain, swelling, limited range of motion. They'll have this rash and eczema. It's not something that just comes, my knee hurts, I'm allergic to the implant that's inside. It usually takes months or years from the arthroplasty. And remember, this is always the last diagnosis after you excluded anything down the list, and it's not infected, nothing else. So now all of the more debated stuff, the positive patch test, the T lymphocyte infiltration, and the resolution of symptoms when implants removal. So if all of these are positive in those rare cases, you may have a patient that actually had some problem with his implant. Again, it didn't say that the implant did not fail prior to that, and not that the allergy caused the implant to fail. So probably the incidence of metal hypersensitivity is way below 1%. We said more in women. Overall prevalence with metal implants. And you can see here a little bit the different, from the different joint registries, at least how it's recorded. So what about all this pre-implant testing, and should we do it? You'll come see in the end, we'll say that there's no reason to test people prior to surgery. So the options include, if for some reason you decide to, it's skin patch testing, lymphocyte transformation test, you have the modified stimulation testing, and leukocyte migration inhibition. So I actually had once a skin patch test due to some reaction in my hands from gloves, and it's very itchy, it's not fun to do it, you can't shower well for a while, and you probably sleep in the guest room. So I wouldn't have my patients go do this unless there's a really good reason for it. And when you look at the testing, you can see all the different studies, not really finding any correlation with much doing these skin tests and trying to find the alloys of allergy. With the transformation test, it's a little bit more interesting. Let me skip this one. And we'll talk about it a little bit later. So there are some hypoallergenic implants. I didn't mention I do have some conflicts with Smith & Nephew, but I'm not promoting any of the implants in this talk for any reason. So you can see there's different implants out there, different companies have different colors. So if you look at the question that was asked in the Delphi study asking about allergy screening, you can see the majority of people say that there should not be any screening, and even if the patients were positive, they'll still continue using cobalt chrome in them. So that's kind of out there. So I think the key points is that pre-implantation screening has a very low predictive value in identifying. Self-reported metal allergy is not reliable. If you do have a patient that tells you that and you have an option to use a different implant, it just takes one headache out. That's how I do it. There's not a lot of literature to support that. Many patients with positive screening will still have a successful joint replacement using cobalt chrome implant. A significant proportion of patients who develop the metal hyperallergy will have a negative pre-implantation screening test anyway. And metal hypersensitivity is not necessarily the cause, but maybe a symptom. I don't think there was ever good studies just testing many patients with well-functioning joints or non-functioning joints and to see their allergy to the implants over time, because they've been living with this metal in their body. The body develops some positive on testing. Doesn't mean it's a cause for failure or a cause to do anything. So to summarize, I'm not sure this is something that we need to address too much. If a patient says, I'm allergic to something, you have an option not to use it. One less headache if they have pain because of their patella. We talked about patellas before. You won't think it's the metal. And besides that, I think most of us will probably develop mild reactivity on the leukocyte test if we have an implant in for 10 years. So we have to take that also with a little bit of caution.